Hi, everyone, and welcome. I will get started as people are joining. Thank you so much for joining today. My name is Jeremy, and I am a representative of EHN Canada. EHN Canada is a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located in British Columbia, Alberta, Ontario, Quebec, and Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at www.ehncanada.com. Just in terms of housekeeping, everyone is on mute and cameras are off for today's webinar, but please feel free to use the Q&A box located at the bottom of your screen to submit questions for our speaker. We will try to get to many questions as we can at the end of today's session. If you're wanting to turn the chat preview box off, please check the up arrow located at the right of the chat box and uncheck the chat preview option. Please remember that this is a professional and inclusive space, and offensive commentary will not be accepted nor tolerated. Today's webinar is being recorded, and we will be sending out a copy next week in a follow-up email, along with the slides presented today and additional resources, as well as your CEU certificate. Again, the recording, resources, and CEU certificate will be sent sometime mid to late next week. I am located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. We also have presence in today's webinar located at our Edgewood facility in Nanaimo, British Columbia. They are on the traditional and unceded territory of the Coast Salish peoples, the traditional territory of the Snuneymuxw First Nation. Vancouver is on the unceded territory of the Musqueam, the Squamish, and the Tsleil-Waututh nations. If you are new to this work and want to find out whose land you are on or grew up on, please check out www.native-land.ca. Many more of you may be physically present elsewhere, and I encourage everyone to use the chat function to, where applicable, share whose land you are on. Now to get to today's session, ethics and mental health and addiction treatment practices. We have Dr. Christina Basedow. Dr. Christina Basedow has a strong passion for working in the addictions field. She has been working with individuals, couples, and families struggling with substance misuse issues, mental health disorders, and codependency issues. Christina is skilled in a variety of areas, including family counseling, eating disorders, sexual compulsions, and CBT/DBT. Christina brings her personal experience, compassion, and a wealth of knowledge in psychology, research, and teaching to her clients and to EHN Canada. Christina is registered with the BC Association of Registered Clinical Counselor and holds a PhD in psychology. She is also currently a certified sex addiction therapist. Please help me welcome Christina.
All right, thank you so much, Jeremy. Good morning, everybody. It's so bizarre to not see anyone. You kind of talk into the abyss. So I was joking with Jeremy earlier that this topic is not always seen as the most exciting topic or a topic that gets people super pumped up. I don't know how many of you are, I'm assuming, have done either, bachelor's graduate work, and, we have a mandatory ethics course and we have to talk about it and we have to identify, how we're impacted by it. And at the same time, a lot of those conversations become quite dry, right? We don't actually spend a lot of time talking about the importance of ethics and mental health practice and addiction treatment practice. And so I'm going to attempt to make this not boring, but I am also going to cover like a pretty significant amount of information that we have to talk about. And then it kind of gets good when we talk about, more things related to concurrent challenges, or when it comes to transference, counter-transference. But really, I hope that this is sort of a really great summary of the importance of why we need to talk about ethics and mental health and addiction treatment practice, and that it feels a lot less boring than the mandatory courses that you had to attend while in grad school or wherever else you may have gone to school. So the learning objectives, I think they've been publicized also by Jeremy and his team. Really what we're trying to look at in this presentation in our hour that we have together is, how do we define ethics and mental health and addiction treatment practices? How do we look at what are the differences and similarities between our general ethical constructs that we abide by, whether it be societally or whether it be in general business practice, and clinical guidelines, because there's a huge difference between the two, and there's also similarities. What is the impact of counter-transference and transference? What is the impact of dual relationships? I mean, I think for many of us, we end up in the field. We may end up working in either a treatment center setting or a clinical setting. And some of you may be coming from smaller communities where you may see people that you've worked with in different capacities. So how do we manage dual relationships? And then also talking about, an overview of some emerging topics related to ethics and mental health and addiction treatment practice. So why am I, the best person to talk to you about this? Well, Jeremy, thank you for the great introduction. So currently I'm working obviously within the EHN Canada in more of a sort of business and clinical role, overseeing inpatient facilities in our unit. That said, I also have a private practice on the side that I still get to do some clinical work out, which I love. I also do clinical consultation with some of our clinicians. But, I've also really experienced the ethical dilemmas and challenges being in different positions within an organization, different levels of management, different levels of clinical. We're very blessed that in our, work, especially in addictions, we also are able to see a lot of our success return to site. So we have alumni that come back. That poses its own host of dual relationship challenges. I also live in a small community, so we do see a lot of those places come up and impact things. So we're going to try and talk about those things. Obviously, questions will come, and I look forward if there are any. What I wanted to start us off with is actually a little bit of a deep dive into, take a look inside, because I can't see anybody, so I'm just going to assume you're doing it. We're going to talk about morals versus ethics. I want to say that they impact each other. There's an absolute correlational relationship between the two. That said, they also need to be distinguished from each other, because we sometimes use what we morally hold valuable to impact what we see as ethical. So there's important distinctions. So morals, and this is where I'll ask you to turn inward to make this a little bit more interesting. Morals are your personal values. Okay. What do you believe is right and wrong, good and bad, right? It comes from a variety of life experiences, from groups that you may belong to, from experiences, how you may identify what's happened, right? And if you take a moment and look inside, I'm not going to go on a big morality tangent, I promise. We're going to go to ethics mainly, but morality is fun to talk about. There's a gray area to morality, and people exist with different levels of morality, and I'm not judging them to be good or bad, but we exist differently, right? And for those of you who are big into research and have done any moral ethics research, you'll look into, the questions of how do we, for example, there's a lot of research around saving multiple people versus saving one people, the moral impact of those things, right? We look at all these places. So morals are all about what we personally believe to be right and wrong. Now, the beauty of morals is it holds a social fabric. It definitely allows us to connect on things that what we believe in. Ethics are different. Ethics are used to examine and evaluate how and why particular moral values affect how people see, reason, feel, and behave. Okay, so when we look at the two, the ethics component is sort of like a macro view of our morals and values, right? Because we're taking a step back and we're going, okay, ethically speaking, I have to assess an entire situation, which takes into account people's morals and values. And I am looking at how people will see, behave, feel, be impacted by a situation. So when we're talking about working within this clinical space, we really want to take a look at the fact that when we're looking at any work, individual to systemic, macro, micro, it doesn't matter. We're evaluating decisions, policies, and practices from the perspective of ethics, not from the perspective of morals, because it changes the dynamic. And for those of you who supervise counselors or who are in conundrums that have ethical violations or boundary issues, it's really a very unique opportunity to step back and look at things from a larger lens, because it depersonalizes oftentimes some very personal, challenging issues that arise within the field of mental health and addiction when we're dealing with ethics. Because realistically, we're only often talking about ethical issues when there's been a violation. And we're not always having the conversation prior to, which I think is also a deficit, which we'll get to as well. So I'm so happy that so many of you are here. When we talk about ethical principles, so ethics offer fundamental principles. They offer a framework to us. They offer a framework for us from a cognitive perspective to address dilemmas. They allow a framework to review conventional practices. And the principles that we see predominantly impacting the fundamental framework of ethical decision-making is autonomy. So really went from an autonomous perspective, am I, autonomous in this? What is my autonomy? What was the other individual's autonomy? Compassion, which is a fundamental principle of ethical decision-making, which not everyone knows. And how did I view that from a compassionate lens? Did I take into account all the perspectives? Did I understand that there's, especially in clinical work, there's so much heart, so much care present that we have to look at it differently? Because all of us, I don't know who's in the room, but many of us have been deeply impacted by our clients' work. And we have to be compassionate because we connect emotionally. And for many of us, and myself included, one of the most powerful components of our clinical work is going to be the therapeutic relationship. Well, what does that mean? That means that how my client behaves, interacts, creates a framework within our world, our dyad, or if you're doing group or couples counseling, we need to have compassion when we're looking at that framework because it helps frame decisions, right? When we genuinely care, it changes how we interact. And the closeness that is established within clinical work, therapeutic closeness, also can lead to things like counter-transference and impact the ethical relationship guidelines as we move forward. Confidentiality, obviously a big one. I mean, all of us know the importance of confidentiality, that is really how we hold safety for the people that we work with. But additionally, we have limitations to confidentiality. And how do we address those from an ethical framework as well? Of course, doing no harm. So identifying that no matter how we see ourselves as equal to our clients that we work with, or how much we see ourselves in that capacity, we are still in a position of authority or power. We have to be mindful of that at all times. And doing no harm is a really important component. The framework or fundamental of being helpful. I don't think anyone gets into any field from mental health and addictions perspective where being helpful isn't part of the why we do the work. And then, of course, another fundamental principle is that we're aiming to prevent or reduce harm and suffering, right? So especially in the fields of addictions and concurrent mental health challenges or mental health challenges on their own, preventing and reducing harm and suffering is obviously a large one for us. So ethical values are also something that we look at too. So ethics provide foundational values. So we just talked about, what are ethics, and I'll go back so everyone gets, what are the ethical principles? What are the fundamental principles? Now we're moving into foundational values. Okay, so when we're looking at ethics, and I think ethical thoughts, guidelines, assessments happen so automatically that you don't even really realize that you have fundamental principles, but you also have guiding values that allow you to conduct, think, make decisions. And those values that underlie ethics are fairness. So am I assessing this from a fair perspective? Am I looking at all of the evidence in a fair way? Am I taking the time even to find the evidence? Privacy. So someone's right to privacy. Even if someone has violated an ethical code of conduct, do they have a right to privacy? I mean, these are some provocative questions, right? Does it depend on the type of harm? Does it depend on the type of ethical violation? We'll talk about that as well. Respect, right? The foundational value of respect. Am I doing this in a respectful way? How many of us, again, a moment to personally reflect, and I'll talk about myself as well from a disclosure perspective, have been impacted by an unethical decision within this field? Again, if I had a hand raising, I'm sure there'd be many. When we look at that, it is very easy when someone's potentially poor choice that's causing us to look at something from an ethics perspective, or a challenging choice or whatever happened is made, our own emotional reactivity can lead us out of that fairness, respect, privacy, safety, because we are so protective of the therapeutic relationship of the people that we're working with. For myself personally, I have a really, my own personal challenge that I know I have to consistently work on is the ethical violation of when someone engages sexually with a client or a past client. That for me is like, ooh, like I notice it viscerally impacting me. It is very hard for me in the exact moment that I'm aware of that information to stay grounded in fairness, privacy, respect, due diligence, right? Look at the fundamental principles because it feels violating for me as a therapist. I'm assuming it would feel the same for many of you if you were in that position. So a lot of our ability to take an ethical framework also comes back to our own ability to understand our own transference issues, our own biases, our own, I'm going to use the word triggers in this way, because we all have them, where we know that if we hear about it, we're flooded with our own moral, like, oh, I can't take that. And then, okay, wait a minute, we have to look at it from a bigger picture, right? And so I guess when we're doing these ethical things and we're talking about transference and we're talking about ethical decision-making, self-care, I'm going to segue the self-care thing, is really important. You have every right to take time and space and all of those things. Obviously, immediately deal with any issue that's safety related, that's obvious. But after that, taking the time to reflect back on the values and the fundamental principles. Safety, I just said that. Safety is a big one. How are we protecting the safety of our clients, the safety of a vulnerable population, the safety of our, let's say, our practice, even things like reputational safety, business safety, center safety, right? There's so many things depending on where you work. The value of a meaningful life. Okay, so when we make decisions, we're often using an ethical framework because we want to allow individuals to reduce their harm and suffering, but also find meaning. I mean, isn't that just the goal of deep therapeutic work, right? And then also the foundational value, which I think is really interesting that that's what's in the research, is hope. The ethical value of hope. I am intending through my decision-making and my ethical code of conduct to instill hope, okay? For many of us, we are one of the first healthy adult relationships that is experienced within a clinical setting or within a work setting or within a foundational setting, right? Hope is instilled when I make proper value-based decisions, when I uphold an ethical code of conduct. So the power of ethics and the impact of ethics, I think it's unfortunate we can't make a really exciting course about it. Maybe we can, maybe that'll be the takeaway from today, but there's so much to it and it impacts so much that I really like that we can take a moment to pause and look at the values of that are fundamental to ethics. So now we're going to talk about the difference between general ethical guidelines and clinical ethical guidelines. So if anyone's calling in or watching today from more of a general workplace, right, not a clinical one, you can see both. And for those of you who have worked outside of clinical settings, I hope that you'll be able to pull and draw some of your own personal comparisons. So what we know is that in any workplace that we work in, there are a set of values, moral principles, and standards that need to be upheld by employers and employees. We often see this in, code of conduct, acceptable, unacceptable behavior, what's terminatable, what's, when are you going to be at risk of potentially losing your job, et cetera. And those are typically derived in a code of conduct document where there's specific values present, right? So integrity is a big one, responsibility, respect. The idea is also that many of these ethical guidelines are also derived from laws and industry regulations, right? So in some sense, what's fair work, even things like upholding standards of work practice, averaging agreements, ensuring that, there's no theft in the workplace, really some basic principles. And then we're asked to adhere to them. So when you're adhering to your general code of conduct in a general professional setting, you're actually adhering to general ethical guidelines, right? Companies' rules and regulations are one of those examples. The respect of company property is one of those examples. Maintaining professionalism or professional relationships in the workplace would be a guideline. And then also demonstrating accountability and upholding the trust of where you work or where you're present. So those are examples of general ethical guidelines. Now, those seem, I think, standard. I mean, correct me in the chat if you think I'm wrong, but standard, right? And I think in a lot of ways, this is sort of the foundation that we see that then gets layered upon as we move into the clinical work. So clinical ethical guidelines, they're distinguishable from general ethical guidelines because what happens with our clinical guidelines is that they're directed specifically at the professional conduct of a mental health practitioner. So I want to say we're upheld to a higher standard due to the work that we do. And so when we look at our codes of ethical conduct, because we are working primarily with potentially challenging situations, people in vulnerable positions, individuals who may not be fully cognitively present, obviously the impact of addiction, the impact of being under the influence, many things. There's numerous written codes of ethical conduct across many different countries and professions, right? We specifically, and in Canada specifically, follow the Canadian Counseling and Psychotherapy Association Code of Ethics. It's very rigorous. It's very large. They have a small book as like a cheat code, and then they have a large book that you would have reviewed if you did any sort of type of graduate work or anything else, or we're doing practicum work, etc. And the idea is that there's a standard general ethical conduct that we would expect in a workplace. And now you've entered into your clinical work, and now you're held to a different standard of ethical conduct. Now, it's interesting because we don't talk about that, at least not in my school experiences, not even in my professor experiences teaching. I don't know if we warn the individuals coming into the field of that level of conduct, because you're expected to uphold your ethical code of conduct from a CCPA perspective, even really when you're not actively working, right? And that's different. And for some people, that feels like overreach, okay? For some individuals in this field, that feels like overreach. Let's say, I'm done at 5. Do I need to uphold a code of ethics when I'm outside of work? Well, actually, yeah, because there's rules around how we're allowed to engage with past clients, with people that may be seeking services, with people in vulnerable positions. That's interesting. It's something we don't spend a lot of time talking about. And when we look at the CCPA Code of Ethics, it really sets a guideline of professional conduct for all of its members, okay? So if you're doing counseling work and you haven't seen this, please see it, because it's really actually a very well thought through document. It's a bit big to read, but it's worth the read. The other thing the CCPA does that we don't talk often about is it informs the public that they serve the standards of ethical conduct that members are responsible to uphold and for which we can be held accountable. So if you were to just Google, if anyone in the world Googles CCPA, you can search very quickly as to very specific topics, what is appropriate and not appropriate. And then in addition to the code of ethics, counselors and therapists that are working in the field are expected to adhere to the standards of practice. So the CCPA have taken, not only is there a code of ethics we need to stand by, which is fundamental in its values, its principles, it's guiding the practice, there's also a standards of practice. So it's a double layer, and I think that's important to differentiate. And it's also, if you're working in a private practice or you're working in a larger practice, these are really great decisions to have. And I preface them by saying without consequence. Like if you can have some really deep, great conversations around ethics within your workplace without there being fear of, termination or all that stuff, you can get some really interesting and unique data from your staff, from the people you work with, around what they believe either violates the code of ethics or doesn't, or where they stand on standards of practice. So it can be a really unique decision or unique conversation starter. So when we look at the expectations, and this is where we're now digging into like our clinical practice, what are the code of ethics? So I'm giving you like a CCPA review, okay? So you don't have to Google everything. Basically, that's the goal. And hopefully many of you know this already, but we're looking at the fundamental principles again. So we're back to the beginning, fundamental principles and values. So CCPA basically looks at this. This is the foundation, and I hope that everyone, when they look at that, can go, yeah, I'm on board with that. This is what we're signing up for from an ethical perspective. Beneficence. So I'm proactive in promoting the best interest of my client, not my best interest and the best interest of the client, but truly the best interest of the client. Okay. So I hope this webinar is useful in the sense that I'm trying to hopefully get you to look into yourself. When is this challenging for me, for you? Obviously, the best interest of the client should be front and center, but sometimes it goes against what maybe you would like to advise a client to do, right? Or it goes against maybe one of your own values, because it just does, right? And so there's these pieces that we have to remember. Fidelity, right? Honoring commitments to clients, maintaining integrity in counseling relationships. Okay, well, fidelity is a big one. Okay, I'm honoring my commitment to my client. Even the act of taking on a client, the promise of potentially helping somebody, is a commitment. That's why we talk about, have a plan for if you can't see that client. Make sure you screen your clients, because letting your client go can be an incredibly painful experience for them. It can be counterproductive. It can flare up huge attachment-based issues from the past. It can flare up many different things depending on the presentation of the client. So I always say, like, the code of ethics can be used to guide our practice. And then what does maintaining integrity in counseling relationships look like? My own personal integrity, my own boundaries. What are my boundaries around interactions with clients, around professional interactions, etc.? Big words, non-maleficence. So refraining from actions that risk harm and not willfully harming clients. So refraining from actions that risk harm, I would argue, again, screening properly, ensuring that we're taking on clients in a way that feels safe for us, but safe for them. And then not willfully harming clients. What does that mean, right? It seems obvious, but I think sometimes harm can be subtle. So what would that mean? What have you seen in your own practice? Autonomy. That's a big one. How many of us, either as young grads or as we move into what we believe in and dedicate our lives to a certain track of work, relate to this being a challenge? Respecting the rights of clients to agency and self-determination. Again, take a moment, reflect in. How many of us have sat with a client and said to ourselves, oh my goodness, like that's the worst decision. Don't do it. Don't do it. I mean, not out loud, in your head, okay? In your head, right? Saying, oh, like, and respect actually looks like, okay, I'm here to walk you through whatever it is you're experiencing. And our clients have the choice to continue on in their whatever situation, even if we feel like we could lead them to a totally different pasture, right? I mean, yes, we want to take safety into account, et cetera, but I guess my reflection is how many of us struggle with that, right? There is great responsibility in this profession. There's great responsibility in clinical work, period. But it can be difficult to watch choices that our clients make that we may be in the back screaming like, oh, in our heads. No, don't do it, right? Justice. So respecting the dignity of all persons and honoring their right to just treatment, right? Have we all done our own work on our own biases? Have we all taken the time to look at really deeply into the field of equity, diversity, inclusion? Have we started to educate ourselves around the impact of colonialism, the impact of discrimination, the impact of many different things that allow us to ensure we're not operating in a blind window, that we're really respecting the dignity of all people, and that it's okay to have biases as long as I'm working, to uncover them, to learn about them, to grow about them, and I'm not outwardly projecting them onto my clients, onto my people, right? Societal interest, upholding responsibility to act in the best interests of society. Whew, that's a big one. So that's in our code of ethics, right? That's a big responsibility. Am I upholding professionally what is in the best interest of society? Feels like a lot of responsibility, right? So when we look at the differences between general and clinical ethical guidelines, I think it's really important to note that clinical ethical guidelines are directed primarily at the professional conduct of counselors and therapists, okay? So that's what sets them apart. So when we look at the CCPA, they outline specific responsibilities of counselors and therapists. So these are what we would have to be responsible for. There's many more, but some of the key ones that we look at is confidentiality. Again, there are, of course, limitations to confidentiality when it comes to abuse, harm to self, suicidality, et cetera. So those pieces, of course. But the rest, confidentiality, how am I maintaining that? How am I maintaining that sacred space, that sacred trusting relationship? Duty to warn, again, that would be something that we're responsible for. We have specific responsibilities and duty to warn. Client rights and informed consent. Okay, so that's a big one, especially within environments. I don't know how many of you are calling in from environments where you're in, let's say, a treatment center or you're in a practice where Sometimes, or you have mandated clients. That's another big one. Many of us will see mandated clients, either court mandated or other mandates. I would argue sometimes families are mandating, right? People to either come to treatment or get help. So what are the client's rights in that? And how do we take the time to really explain informed consent? Because really, like, if someone feels forced to be present in a therapeutic setting, that actually doesn't set us up for any therapeutic success, but worse off, it sets up someone to potentially feel marginalized, controlled, not like they have choice. So in the relationship you're setting up with mandated or strongly recommended clients, have I taken the time to ask them, like, do they feel like they have a right to say what their treatment looks like? Have I asked if they feel like they have informed consent to those pieces? And then, of course, very important, maintenance of records for those of you that are in any type of clinical work. Are we making the notes appropriate? Are we tracking them? And I myself have really recognized the importance of that, being called into many legal cases I would have never seen coming, where counseling notes are requested related to something completely different, right? And so it's important to note that even if all is well in the world, you never know what will happen, where the maintenance of your records and your own professional accountability and reputation could be on the line if those records aren't maintained properly. So important to note. And so the general ethical guidelines obviously are applied across general businesses. Clinical ethical guidelines typically only apply to professionals working in a therapeutic and counseling setting. And I think the really cool part about the CCPA being so publicly open with their documents, you can find so much online, clients can seek them out too. That also means that our clients are hopefully informed, or some of them at least are informing themselves as to what ethical practice looks like, and seeking out therapeutic relationships where those things are part of the package, right? So the similarities, though, because the differences are obviously quite clear, but the similarities that we see is that they're both rooted in values that are designed to conduct a safe and appropriate work environment. And really, the reason that the clinical guidelines are differentiated is because we actually have more risk, more safety to be aware of, more safety to take care of with our people. And there's an overlap, and many ethical guidelines that you may see in a workplace that isn't clinical can also overlap with standards of practice, right? And I think that's a very interesting piece to note too. So just because clinicians or therapists or those doing clinical work are held to a higher standard, it doesn't mean that you don't see those high standards apply somewhere else. And so many of those are on issues such as sexual harassment, diversity, responsiveness. Majority of workplaces, thankfully now, have elevated into making sure that safety, both workplace bullying and harassment wise, the impact of negative situations in the workplace, and also just the right to be having that be brought forward in a really rigorous way as part of the workplace. So those things would overlap and be similar. Okay, so now, okay, I'll take a pause. That's the chunk of ethics that are related to CCPA, general ethical guidelines, kind of the meat, the teaching part of the part. And now I think it's really important to talk about what are some of the, I'm going to use the word threat, but I'm going to use it loosely. So what are the threats that we see that impact ethics and values within the counseling relationship, and what comes up for us that can come up, sneakily and citrusly, we don't even see it coming, but it really does come to the forefront. So transference is probably is one of the biggest ones for me. And I think when we look at it in a therapeutic context, we're really talking about your client's subconscious projection, of feelings about another person onto their therapist. So when we talk about transference, we're going to use those things of, fairness, compassion, etc. Take a moment. How many of you have experienced transference? Okay, so transference, a client and a therapist are interacting. It can be in a group, it can be individual, it can be in a dyad, it can be in a couples, it can be anywhere. They are looking at the client's biased thoughts and beliefs, typically, that's where they're foundationally coming from, and the transference occurs. So your client comes into your space, whatever that space is, wherever you may be. They come in with their own host of world experiences, positives, letdowns, challenges, traumas. And as much as therapists try to be a somewhat blank slate, we all have personalities, looks, cultural backgrounds, many different diversity pieces that impact our interactions with others. And so a client is going to have these potentially biased thoughts or beliefs. You may look like someone, you may have a voice tone of someone, your office may inspire feelings. There may be, it's subtle and I want to say it's an unconscious process most often, depending on the level of awareness that your client may have. This is typically an unconscious process. I mean, the example I have on here is a client has a negative relationship with a parent figure, transfers the feelings associated with the relationship onto their therapist. This can then result in the client developing a hostile or dismissive attitude, fear, difficulty trusting. So have you been in this space? And what happened for you? Did it challenge you, right? Because you can flip too, right? Like you can be having rapport, it seems to be going well. Maybe you engage in a challenge with your client, you challenge them to look at something, and energy shifts, right? Oh, what did I just trigger? Like what happened, right? Now, depending on when this happens in the relationship, sometimes we're able to be curious. We're able to walk it through. We're able to actually say, hey, like I noticed the energy shift. Like what happened? What did I remind you of? Like is something going on for you? Like what's coming up? What are the feelings? What did I trigger? Right. And that can lead to some really great, like deep work, right? But sometimes those repairs are not possible. Sometimes our clients choose not to come back when they're impacted by transference. Sometimes our clients choose to have really unhealthy relationships with us, or push for maybe there's something they push for that feels really icky for you as a therapist, right? Like think about these pieces, but transference can cause ethical alarm bells to ring. And they also are a key period when you're noticing those things shift and you're not able to regulate that with your clients. Do you have, clinical supervision or a trusted colleague that abides by the same code of ethics, or someone that you can work through those things with to help uncover what would be in the best interest of the client when there is transference? Some transferences we can get over very easily. We can walk it through. Some we can't, right? And some we have to really take the client's best interest and say, I'm noticing this. Maybe we need to do a different direction. Maybe we need to seek out a different type of support, et cetera, et cetera. So that's a big one. Transference is a large one. Again, something that the counselor themselves really doesn't have control over, happens often unconsciously, but we do have a responsibility to work and help the client uncover how to move past transference if it's possible. And that's where our ethical duty would come in that case. Counter-transference. One of my favorite topics, because I don't know about you and about all of you, there's many of you, but I don't know about you, but I truly believe that in order to do this work well, we have to do our own work. That's my own personal belief. I'm not saying that has to be yours. But I know for me, a lot of my own therapy that I still attend on a monthly basis, more if I need it, I guess, but a lot of my own stuff that I had to work through helps eliminate countertransference. That said, it's not impossible. It happens often. And for us, it sometimes happens unconsciously. So countertransference, the projection of a therapist's feelings towards the client. Okay, great example. A client brings up material that's sensitive to the therapist, which in turn causes the therapist to avoid the topic or react defensively or become hostile or become biased towards the client. Okay. So like transference, countertransference tends to be inappropriate in nature, where reactions are uncalled for or patients are not deserving, right? The big one here is the impact it can have on the therapeutic relationship and the outcome of therapy. So therefore, it's essential for us to become aware of countertransference and take some appropriate steps in order to avoid it. Well, what does that mean? That sounds really nice. Like, what does that mean from an ethical perspective? What are the steps I'm supposed to take? Like obvious ones, okay, sure. Clinical supervision, going to your own therapy. Those are maybe some obvious ones, right? But it's not always that easy, because how many of us have been in situations with clients not fully aware that countertransference is happening until later, right? Not fully aware. So I'm having this interaction. Some of us notice it with, let's say, a client that we just out of nowhere don't really like that much anymore. I mean, I know that sounds, I'm just trying to speak very openly, right? We notice that, oh, I see Bob in my calendar today. But I really maybe had a great relationship with Bob a while back. So what's happening, right? What is the countertransference there? What got brought up for me? What got triggered? Like, we are all human. And I think sometimes because we're in these positions of trust, we have challenges accepting our own fallibility, our own, I don't know about you, but it almost can sometimes come across as like, oh, did I not have good enough boundaries? Did I let my client down? Did I not do enough work on myself that I ended up here? Like, countertransference and transference have not always been spoken about from a strengths-based lens. Oftentimes we saw them as weaknesses, right? Oh, I can't believe that this counselor was impacted by this patient. Like, that's ridiculous. They haven't done their own work, stuff like that, right? Really harsh, not trauma-informed language around the fact that, wait a minute, this is completely normal. This is a completely normal experience when I'm working in the field of human relationships, because that's what we're working in, the field of human relationship. And it's okay. It's okay if I know how to manage my own feelings, right? It's never okay to become hostile, biased, discriminatory, inappropriate towards a client. I'll never say that that's okay, but the act of it happening is not abnormal. And so our role is like, and I think that's a lot of the work that I do in the clinical supervision I do, is like, okay, in the moment when you're noticing this flare up, and it flares up for all of us differently. Some of us feel heat in our body. Some of us just feel dismissive. Some of us stonewall. Some of us just are wanting to avoid the topic. Some of us can get emotional. Like, there's many different responses. So the biggest tool that you have in your tool belt when it comes to countertransference is your own emotional regulation, right? How emotionally regulated am I? What happens for me when I get dysregulated? Can I flag it for myself before it becomes visible or overly visible to a client, right? And that's a really key one. That's an antidote to countertransference, because you can take all of your feelings away later and talk to someone, trusted colleague, a clinical supervisor, someone else that is in your workplace that abides by the same code of ethics, if that's a possibility in a team-based environment. And you should have places where you're able to speak openly, honestly, without filter to what's happening for you. I think that when we get to a place where we notice ourselves blaming the client, we're probably experiencing countertransference, I would argue. If you want to debate that, though, I'm happy to. But the minute we start blaming someone who's coming to us in a vulnerable situation, we're probably engaged in countertransference unconsciously again. And so I think those are some really important pieces in when we look at countertransference, that we're really choosing to practice our standards of practice and our ethical guidelines, which are fairness, compassion, respect for ourselves as well, not just for our clients. And emotional regulation can look many different ways. Now, you may also come to a point where maybe you haven't done a layer of work that you might want to do or you need to do. And so you're not going to accept a certain clinical profile because off the hop that might be too triggering for you. It may be more useful to screen out clients while you're doing your own work, your own, deeper dive as you move forward. So those would be some steps that we could look at to actually avoid things that are happening within our own practice. I hope that's not too deep a dive into countertransference, but it's a big deal and it impacts everyone. And I feel like we don't talk about it a lot because there is this, in some ways, there has been almost a weakness associated with it, that we got so impacted. And I think it's important that we kind of strip that away, and that we also help the next generation of people that are coming into the field accept that that's okay, as long as we know what we're doing with it. Dual relationships are also a big one for me. I'm just going to check something on my slides. Yeah, okay. So dual relationships are a big one in the sense that the mental health field, we see them often. And they co-occur in various forms. And so basically what we're looking at is when there's multiple roles that exist between a mental health practitioner and a client, okay? So the types of them, social dual relationship. Okay, that's a challenging one. The therapist is also a friend or an acquaintance or a, I don't know, friend of a parent of a child that you interact with, et cetera. So there's a social element. You're seeing this person in a social setting. Now, dual relationships, I want to say, and I'll speak very openly about how I see them unfold. There are some risk factors to having them happen more often. Obviously, the size of your community is one of them. I think additionally, we see dual relationships come up in a recovery-oriented setting. We have many individuals, for example, especially in small communities, but sometimes not. If you as a therapist may be in your own personal journey of recovery, whether that be addictions, codependency, maybe it's behavioral challenges, maybe it's just your own personal growth journey and work that you do outside in a spiritual capacity, whatever it may be. But there is this definite linkage when we look at recovery community and we look at even recovery-oriented systems of care, or we look at the impact of group recovery meetings and the positive impact that they have on recovery capital. We see that often crossover lots, that we'll see a client or a patient, however you call them, come from a certain setting and come into a recovery meeting, and you may also be attending that recovery meeting, right? Now, yes, recovery meetings are confidential. They are rooted in the safety that is established by their own code of conduct and guidelines. That said, that can feel both uncomfortable, but also like we want to connect and support from a recovery lens. So that's a common place that we see dual relationships exist. There are professional dual relationships too. So the therapist may double as a work colleague or collaborator or consultant, right? I may see that person not only in a therapeutic sense, but they may actually work with someone I know or come in and work with a company that I'm in. Business dual relationship, that's one that we also see. The therapist is involved with someone in a business capacity. So that can be many different things. Maybe you have gone to therapy or you went to a treatment center and you also get your hair cut by someone that went to the same place, right? There's dual relationships that exist. Therapeutically, though, when we look at the communal dual relationships, the therapist and the clients are members of a small community or are members of a small sub-community, like a recovery community or maybe even a church or a religious group or a spiritual group, and they will likely run into each other or be involved in the same activities outside the office. That may also be a small community of maybe your kids do sports and your therapist, and you see clients within the sport world or within the hockey world or whatever it may be. These communal dual relationships are, I have to wear my therapist hat, and then I also am sort of outside of my work, but I can't engage unprofessionally. And then the final one, again, that flares up for many of us, more of a visceral reaction, is the sexual dual relationship, right? Now, when it comes to sexual dual relationships, I want to be clear that there is in the CCPA code of conduct, like it's really more of a timeline in the code of conduct. I mean, they say that it's not recommended at any time, but if that were to take place, a certain number of years have to go by prior to engaging in a sexual or romantic relationship. And that's something that would also be a dual relationship. The question that we always pose, both to students and practitioners, is even if the time had passed, maybe it's 3 years in that capacity, if the time had passed, and I think it would depend on the nature of the relationship, et cetera, would the dynamic of therapist and client fully be able to shift to allow that to happen in a way that didn't feel challenged or violation based, right? And that's a question that I can't answer for anybody, but that's a question that we would pose in a teaching environment. So dual relationships are challenging in the sense that we see them happen often, but we also know we need to manage them. And they can be managed, right? You don't need to run in the opposite direction when you see a client. It's just about, am I maintaining those standards of practice? Am I approaching things from a macro level? Am I also taking care of yourself? Even if a client wants to engage with you outside of the workplace, am I setting the tone within my workplace? Like, what feels good for me? I see a client, if they approach me, it's great to see them. Nice, how are you? Hope you have a great weekend. But some therapists are like, no, I'm like, when I'm out in the world, like I'm just out in the world, and please don't take it personally. And you set those parameters up front in your practice, right? If I see you at hockey, we're just moms at hockey, but we're not going to talk about these things. Or I may go the other way. Please don't think that means anything about our relationship. It just helps me keep work and my private life separate. All of those are appropriate boundaries. How we set them, though, is how we take care of our clients, right? Making sure we're setting them up front, making sure they're not highly emotional, etc. So I think this is really more just more for what I'm saying already, but we're looking at the power imbalance, right? When we talk about dual relationships, what you have to ask yourself is not, oh, I enjoy my client when I see them in the community. We have to always, underneath the likability, the therapeutic relationship, the connection, all of those things will always exist a power imbalance. The client remains a vulnerable party. They are seeking support and advice, often paying for that from a mental health professional. Okay. And so it doesn't matter whether it's in a treatment setting, in a private office, any place, it really is the takeaway from an ethical perspective is no matter how connected I am to my clients, no matter how many boundaries I've set, no matter how clear I've been, I will always, always, always have a power imbalance underneath in the undercurrent, unconsciously. And that is why I'm bound by a professional duty. And that is why we're bound by a professional duty outside of the workplace, if that makes sense. We are there to protect the client. We are there to not cause harm. And so oftentimes because of that, the danger of dual relationships is the loss of objectivity. And when we lose I don't want to call it a separation because that sounds so easy, but when we lose some of the awareness of the power differential, we can jeopardize the therapeutic relationship in a sense that the client doesn't feel safe any longer. The client experiences undue harm or negative consequences. And really, it's important to protect that safety. That being said, it's not always possible to avoid them. And I think peer support work is definitely an area where dual relationships are very likely to arise with clients. And we see that, again, particularly recovery community-based or other peer support settings. And when we look at the code of ethics, of course, they're designed, they tell us to avoid dual relationships unless there's informed consent and parties are aware. So it may heed you to speak to your clients, and this may be kind of how to get around it. Initially, at the beginning of sessions, at the beginning of the relationship, talk about what that might look like, depending on the size of your community, depending on if you were to see individuals in the community, and talk about how, your job is to care for the safety of this client and to actually make sure professional judgment is maintained, and there's no exploitation. And so being able to have that and set the tone and the parameters actually is a safety mechanism, not only for the therapists, but also for the client. It also helps avoid things like, counter-transference or self-disclosure, gift giving, those types of pieces, starting to meet outside of clinical settings. Like it helps keep boundaries in place when parameters are set around dual relationships. And it's often something I think we forget in the setting of the tone for the beginning of relationships. The other thing I think that's important is, have you told someone about a dual relationship, particularly if it's like an overt one that you're in, right? Have I made sure that I have proper, precautions in place, informed consent? Do I have supervision? Have I put it in my clinical notes, right? Talked to client Barb about dual relationship potential issues, set these parameters, blah, 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 right? That's important, right? Because we're not only protecting our client, that's our primary concern, making sure they're safe, making sure we're not causing harm, but are we also protecting ourselves through documentation and through proper behavior? Finally, the maintenance of ethics, I mean, this may have been a slight ethics refresher course, but it's only an hour, so I'm not going to say it's too magical, but the point is are we really, making sure that we're looking into recent literature, looking into, cultural knowledge keepers, other practice guidelines, ethics refreshers courses, even just going through the quick study guide from the CCPA is a really great refresher. Oh yeah, I forgot that from that university course, right? It can really help maintain a sense of ethical practice. And what are your expectations for the people that you work with? Does everyone have the same page? Are they all on the same page? Do people know? And if they don't, how do we help bring them into the field of best practice? Okay, I was looking at the time. 5 minutes to spare, Jeremy. Yeah, so 5 minutes to spare, I think.
Yeah, no, we're good. Thank you so much for that. Yeah, if we want to get into some questions, we have lots of interest, so we will get going. Okay, first question. Organizations can impose unethical policies that can cause a great deal of harm to many. Knowing the harm these policies cause, what is our moral and ethical responsibility? And then within this question, they were highlighting the impact it would have on marginalized communities, such as the Black and Indigenous community.
Oh gosh, that's a fabulous question and a highly loaded question. And I hope I do some justice answering it. And I'm a very visual person, so I wish I could see it. But I think the biggest piece is we absolutely have, especially as we grow and we see the impact of speaking truth and really becoming educated in these things. I really feel like we have the I almost want to call it a moral imperative because it's really based on values. Like that's what we're talking about. I really do believe we have a moral imperative to bring light to what can either feel like or is overtly discrimination and things that go against inclusivity and against acceptance of all. Like that is our absolute, and I feel like that's even as mental health practitioners, our absolute imperative to do so. Like I feel like it's a moral imperative. So I would say, I don't know if I'm even answering the question. I think for me, it's like push through it to actually get there. I think there's always risk. Like people get very scared of impact on job security, et cetera. Is there a way to find safety either in numbers and resources and community resources? How much of it is honestly true ignorance, which is not an excuse whatsoever, but how much of it is real just lack of awareness, understanding that we could create from education or help solve with education. How much of it is true discrimination, which is an even larger topic that I don't know if I could do justice answering. But again, I think the imperative to push forward to change policy, and I've seen it, within our organization, within many other organizations, that as we learn and grow and we're open to that, we do shift quickly policy procedure to meet that. Yeah, anyways, I don't know if that helps. I'm sorry. If that's not helpful, ask again or put it back in the chat.
No, I think that does make a lot of sense. And like you said, sometimes not condoning it, but it might just be ignorance, right? Where we're able to offer educational resources to, for lack of better words, educate the people on these types of topics and how it might impact those marginalized communities. And it's, like you said, too, important to note that within equity, diversity, and inclusion, it's ongoing. So it's just making sure that people are being updated, and people might not be up to date with most current practices and such. So it's just important to, come from a place of genuine care to educate people, and hopefully that they're going to be a little bit more receptive towards being inclusive and being mindful that it might be impacting those groups directly.
Yeah.
Okay. Okay. So the next question, speaking to autonomy, what if what if what they choose causes harm, and how do they know they are being truthful with you?
Oh yes, loaded question. So I would say that not often, that would be an overstatement, but I think in many cases, clients may choose something that causes them harm, and it may be a variety of harm, right? It could be choosing to stay in a relationship we believe might be, not positive for them. It may be choosing to, let's say, continue engaging in active addiction, even though we know that maybe either a recovery oriented choice or a safe supply choice or a harm reduction choice, whatever that may look like, would be healthier. And I think it becomes a question of what counseling are you intending to do? Are you wanting to support them where they're at? Do you feel good supporting them where they're at? Did you set the tone at the beginning of their engagement with you for that? And I think, are we seeing shifts and growth in other areas? Because therapy is, yes, an element of support, and counseling is there to support people, but we're also in a position where we're hoping to affect change and help lead to better quality of life, et cetera. So I find that turning it back onto the client, not in a negative way, but saying like, what is the goal? Like, what are you actually here to do, right? Because it might actually be my own bias. Like my bias might be, like that's the goal. If they were in recovery and they weren't using, then like we'd be good, right? But it might actually be that they're there to unpack a trauma from their childhood. And if they were to stop using, that would be almost impossible for them to look at. And I'm not saying that's right or wrong, but so it's like, where do we need autonomy? And honestly, you can't trust that you're getting the full story. And are any of us in an hour a week or an hour bi-weekly? I mean, that's something too, is we have to go with what's presented to us and then make the best ethical choices with what's presented. But we also could be presented something that's completely false and not know it. And then we're really just working with what the best pieces are there.
For sure. Yeah, thank you so much. So it looks like we have time for one more question. How do you make use of family caregivers with respect to collateral information, in brackets held in private, to ensure accurate and timely information, particularly with youth who are often not revealing truth? So kind of going off the previous question as well.
Yeah, great question. I think that in a lot of places, and this is something that's been useful, either private practice or treatment centers or counseling centers have really put into place, like, can I have access to caregiver information to paint the larger picture and getting consent to do so? I think it's very useful to use that information in a treatment setting. And I also think it can rupture rapport if not done very well, right? So I think it's a question of how do we build rapport with, let's say, a youth, a great example, with youth, for example, while at the same time saying, hey, like, what would your primary caregiver, your mom, what would they say about this? Is this act, like those types of pieces? And then inviting them in to review the collateral information and do it with them as a partner. Like, I find that works well instead of like kind of an additional parent figure. But yeah, I think if we can get it, like, and it is something that is consensually obtained, then we absolutely should, because I think anybody in our life can paint an additional valuable picture regardless of our experiences. So I would say yes, and then it's such a fine balancing act therapeutically to keep the relationship and also maintain best practice and safety for the client.
Perfect. Yeah, thank you so much. I think to just put it briefly, there was a post in the chat that just said, this was exceptional. Thank you. So I think
thanks.
just highlighting everything within the presentation. Thank you so much again for providing your expertise and insight. I know I learned a lot, and I'm sure a lot of people benefited from going back to kind of basics with terms of ethics and morals within treatment. So just want to say thank you again so much for your time and for your presentation today.
Great. Thank you guys so much. Pleasure being here.
Thank you. And for everyone attending today, just to reiterate, we will be sending out a copy of today's recording, the slideshow that was presented, as well as some additional resources. And we will make sure to include your CEU certificate sometime mid to late next week via email. And we thank you so much for your attendance today. Until then, take care.